All right, I'm going to do another video on EMResource.org website. And the resource pages, we're going to go to practice changing papers. So this is a page that I have basically, I think practice changing papers I think are important, but haven't really been shared or amplified to the degree that I think they deserved. And they're organized by alphabetically. So the first is ACLS resuscitation. Um, So basically for meds don't really work for VFib, earlier is better, and basically amio and lidocaine and placebo are all about the same, especially for shock-resistant VFib. There's a VTAC article from 2017 about giving meds early. There's probably spectrum bias there. People who respond earlier are obviously going to have better outcomes and probably started with less severe disease. Avoid empiric calcium. Corey Slovis has some good lectures on this, but calcium is class 3, so is bicarb in ACLS, does more harm than good. So I've got some articles on this, the COCA trial, and then same thing with bicarb. So basically, calcium and bicarb lead to worse outcomes. So it's not something where you can say, well, what's the harm? Because there is harm, and it's class 3 is ACLS recommends against it, and that's been since 2010. All right, so analgesia. So this one is basically you don't need prophylactic antiemetics, even Zofran with opiates. So before Zofran, they said you don't really need them. It's only a small percent that develop nausea and there's side effects. But even Zofran with fewer side effects, they recommend against it. Remember, Zofran can prolong the QT, so there is potential harm. So less than 20% of people who get opiates develop nausea, and Zofran didn't even prevent it. So basically, just give them the opiate, and then if they get nauseous, sure. Or if they're already nauseous, sure. Order some Zofran or the antiemetic of your choice. I've read good things about Benadryl in opiate-induced nausea because some of it may have to do with histamines. And Benadryl doesn't prolong the QT, but it is potentially sedating. And you can click here if you want to go to the reference paper. These are hot links that'll take you to the paper that I think needs to be amplified. Same thing, here's the COCA trial. So most of these have hot link references. I've started to use more Toradol, but ibuprofen is supposedly just as effective and safer. And if you are going to use Toradol, they really recommend that the ceiling effect for analgesia is 10 to 15 milligrams. So don't use 30, don't use 60, even if you're going IM. And then click here, get the reference to that. This is actually, looks like this is Rebel EM. So I'm not always linking directly to articles. Sometimes I'm linking to other sites. Cardiology. So the heart score, I've done a couple, at least one podcast in EM Logic on the heart score. I would encourage you to listen to it. I don't know what episode it is right now. But there are some good things about it, but it definitely has some blind spots, and I think it's really important to know about these. Yes, your case may be defensible if you miss a heart attack or something like that, but would you rather not miss it? So sensitivity is as low as 93%, and often worse than clinical Gestalt. So this is the article there. My main things with the heart score, I covered that on a different one of these little videos. So you look at the one I posted a couple days ago that has more on the heart score, because there's a whole page on rules. I did a little talk on decision rules, so that's in there. So if you want to know more. Occlusion MI. So this is a new term that's evolving, championed by Stephen Smith. Really, the STEMI criteria miss about a third of acute coronary occlusions that would benefit from reperfusion. So you need to be able to pick up other findings that are, I don't know if they have those here, other findings that are diagnostic of acute coronary occlusion that don't meet STEMI criteria. SVT, so the modified Valsalva is actually about 40%, so it's worth trying. Also, for SVT, diltiazem is better than adenosine. Adenosine came out, it was well marketed. I don't think it's necessarily expensive now, but there's some. I mean, the benefit of adenosine is it's going to wear off faster than diltiazem if there's a bad side effect. But patients hate adenosine, and there are some risks to adenosine that diltiazem doesn't have. So there's a lot of reasons why I reach for diltiazem first for SVT. This one is going to be sort of controversial, and I'm not recommending everyone send D-dimers for acute coronary syndrome, but an interesting article on D-dimer being actually more sensitive than troponin for unstable angina, right? Because unstable angina, by definition, you shouldn't have a troponin leak, even with the new high sensitivity troponins. But it is a temporary clot in a vessel, so it makes sense that the D-dimer could still be elevated. You know, if it was occluded for, say, 5 or 10 minutes, that might be enough to raise your D-dimer, but not enough to ever cause a troponin leak. So, yeah, it was about 95% sensitive, and no, it looks like it was about 95% sensitive for MI and about 65 for unstable angina in this study. So here's the reference to that one. I think this was from Turkey. Yeah, these are some Turkish names. Your nose and throat. Steroids are beneficial for vestibular neuronitis. I read this article ages ago. I think it was in the New England Journal. Oops, maybe British Medical Journal. Looks like I got to fix this link. But typically you should be using steroids for vestibular neuronitis, better outcomes. OB-GYN, transfusions overused for vaginal bleeding. Hemoperitoneum. So, you know, we're taught that hemoperitoneum causes rebound and severe abdominal pain. That's not always the case. I've had a number of patients, I would say, in my experience, maybe a third, if not more, that just feel bloated. I had one that, hurt. She had pleuritic pain when she, shoulder pain when she breathed. She just had curve signs. They don't always have severe abdominal pain or tenderness. So don't be falsely reassured. If someone comes in, a woman of childbearing age comes in saying they just feel bloated and lightheaded, they could have hemoperitoneum from a ruptured ectopic, from a hemorrhagic cyst that's bleeding a lot, something else. Hematology. So I've been teaching this for a long time. I think it's super important to realize that a lot of PEs, probably about 20% of PEs are painless, and counterintuitively, those are the larger ones. And this study showed 2/3 of massive PEs were painless. And the reason probably is because if the clot is lodged centrally, there's collateral circulation, so you don't have any lung infarct. So probably what causes the pain in pulmonary embolism is a lung infarct, which is typically a smaller PE. Now, you can have small and big at the same time if it breaks up. But a large PE that's, say, a saddle embolism, that's going to cause all kinds of EKG changes, troponin labs, vital sign abnormalities, but often is painless. And if there is pain, it's more like cardiac pain. It's not really necessarily pleuritic pain. So it's important to be aware of this. You don't want to miss 2/3 of the massive PEs you see, or 20% of the PEs you see, because you only work up PE if there's chest pain. So 2/3 of massive PEs are painless in this study, and in my experience, about 20% of all PEs are painless. Infectious disease, antibiotics for diarrhea. So I know a lot of people do not use antibiotics for diarrhea, but most of the people who are sick enough to come to the ER with diarrhea have at least one or more of the red flags where the study actually shows, regardless of culture results, that they do better. Looks like I don't have a link to the study though. And then jolt sign and meningitis. I found a lot of people do not know about the jolt sign. This is important right here, the sensitivity of different exam signs for meningitis. So Koenig's, Brudzinski's, those are very non-sensitive. Those are only severe cases. Nuchal rigidity, a little bit better. Photophobia, probably maybe more than 30%, I would say. Maybe more like 50. I think photophobia is important. And jolt accentuation of a headache. I think it's close to 99% sensitive in an alert individual, maybe close to 100. This 70, that may be in studies where you have sicker patients and they're not necessarily as alert. And then on and on, we've got neurology, PRISM studies, minor strokes, the PRISM study, TIA workup, procedures. The Swedish guidelines, I think, are better for who needs a CT before LP than the American guidelines. So this is the American IDSA guidelines. But this is important, I think. Some meningitis typically presents within 4 days. So if you're worried about meningitis but they have symptoms for more than 4 days, they may have a brain abscess or something else, something that presents a little bit more indolently. We've got pulmonology. Hopefully you're already using the years criteria. It basically lets you use a higher D-dimer, and I did cover that in the decision rules lecture, so you can go back and look at that. Renal, they're recommending Veltassa and newer agents instead of Kexlate. Testing, trauma, urology, predictors of kidney stones being infected, reasons why not to prescribe Flomax because it can drop the blood pressure and doesn't really help for most people. And this is a hilarious, well, it's not hilarious, it's hilarious it hasn't been amplified. So supposedly sexual intercourse, I'll leave you with this one, increases stone passage better than Flomax. I guess doctors are afraid to bring it up because they think they'll get canceled or something. And probably people are in a lot of pain, aren't really interested in getting intimate. But anyway, so I will leave you with this study. Look at that, PubMed. All right, so that is again, the practice changers on the resource page, practice changing papers. So please use it, share it, use it to share the articles with other people at work, and thanks for listening.